Hello, today we're going to be talking about diseases of the digestive system. Don't forget, and because sometimes I forget to tell you when we get ready to get started, have a notebook there so you can jot down notes and give yourself the ability to go and look things up as you are listening to me and you think, oh, I need to do more research on that. And then also have your ICD manual there with you. If you have your PCS manual, that would be good too, but it's a little bit easier to go and check the stuff for PCS afterwards. So let's get started on the digestive system. As always, we're going to go over the ICD-10-CM and PCS codes and guidelines that are applicable to the disease process. And we're going to pay a lot of attention to the anatomy and physiology. Why? Because the guidelines tend to be based on those. All right, we are going to talk about the digestive system and the organs. The main organs of the digestive system is the mouth, pharynx, esophagus, stomach, small intestines, and large intestines. Now, we are going to break down the small intestine and talk about the parts as well as the large intestines. And if you don't know the names of the different divisions of the intestines, I would go ahead and memorize those. The accessory glands or organs, excuse me, not just glands, but organs that go along with the digestive system are going to be the salivary glands, and they're often overlooked. It just takes one stone in a salivary gland and you'll never overlook it again, right? Have you ever seen one of those? Go out to YouTube and look at a picture or someone having a salivary gland stone removed. The liver, the gallbladder, and the pancreas are also considered part of the digestive system, but they're accessory organs because they're also associated to other systems that we've already talked about, right? Or we will talk about in the future. With the mouth, we have, of course, the tongue. Don't forget that the teeth end up being part of the digestive system. And what does the tongue and teeth help us do? It's mastication, and that is ultimately just chewing our food. The salivary glands, again, accessory organ associated to that. And if you ever want to know how they work, just pop a lemon drop in your mouth and they'll go into hyperdrive for you. The pharynx is the back of the throat. We have the pharynx and nasopharynx, but what we're dealing with there is the ability to swallow. The muscles that are back there kind of start that peristalsis waves to help food move in one direction. That kind of starts right in that area. The esophagus, and again, that's where peristalsis happens. The esophagus is a smooth tube. There's specific types of tissue inside that lumen, which just means a tubular body, in the esophagus. The esophagus and the trachea run side by side, not side by side, but this way. The trachea is in front of the esophagus. The esophagus goes behind the trachea, and the trachea is part of breathing, and it has cartilage around it to protect it, whereas the esophagus doesn't have anything. It is just a tube that goes from the pharynx down to the stomach. And again, it has specific tissue, but the purpose of the esophagus is to take that food or liquid, the food that's been masticized, chewed up, and then to let it travel to the stomach. Otherwise, it really doesn't have a purpose per se, right? Just it's a pathway, let's say that. The stomach, though, does have a purpose. Actually, a lot of people believe that the stomach is where we absorb our food, and it is not true. It is where the gastric juices are that break down the food for us. So it breaks it down into a smaller liquefies it more or less, or turns it into kind of like a sludgy material, a soupy material. And those gastric juices that are in there break that down so that when it goes through the pyloric sphincter and gets into the first part of the small intestine, then it can be processed to absorb the nutrients. So the stomach itself does not absorb nutrition. That's why you can actually go without a stomach. And people who have had gastric cancer could have their stomach completely removed. The body has to adjust because, and what ends up happening then is we go from attaching the end of the esophagus to that end of the pyloric sphincter, and the food is not digested with those enzymes to the point that it makes it easier to absorb into the intestines. So you can't, it's a lot harder to eat a steak, put it that way, when you don't have a stomach. The body doesn't have that way to break it down. So going back to the accessory organs, let's talk about them a little bit. The pancreas. Now, we know the pancreas is, a major part of the endocrine system, and it helps us with the insulin in our body. But our body feeds or gets energy off the sugar that is in our body. How do we get the sugar in our system? By what we eat, right? So it's directly related. The liver ends up being like a filtration system for us, as the gallbladder does that as well. So with the pancreas, it excretes juices to help aid in digestion, right? So we do have the stomach content has that acid in it. And and if you've ever had reflux or thrown up, or what you've probably all experienced being sick, right? And you've thrown up so much there's just nothing left in there, and then you have that yellow bile or green bile that comes up. That is stomach acid, stomach contents. My youngest son, number 6, here a month or so ago, we were afraid that he had appendicitis. We took him to urgent care. He had all the signs and symptoms of appendicitis. He kept throwing up, but I was hoping it maybe was something else. And they sent us to the ER, and we were sitting in the ER waiting, and they were thinking that it wasn't appendicitis, but they were running tests, and he just kept throwing up. And they got him some Zofran, started an IV. It ultimately ended up being a kidney stone. But after, hours of throwing up, nothing was coming up but the bile, the yellow stuff. And he goes, "What is this in my, that I keep throwing up?" And I said, "Well, that's stomach acid." He goes, "I don't like it." And he said, "Well, it's not meant to be. It's not meant to come up. Not, you're meant to come out." Anyway, I just, that was terrible to laugh at his expense. But again, that's what is the inside of our stomach digesting that food to the point where it can be passed through. And the pancreas helps aid in digestion by excreting those juices. The ducts connect to the duodenum. Now, the duodenum is the lower, that's at the lower part of the stomach. So the stomach, when you look at a diagram of the stomach, and you've probably all seen that, and you have the top and there's a little arch there, and that's got a specific name, and down at the bottom has a specific name as well. And then you get that pyloric sphincter is the little area right there at the end of the stomach before it goes into the duodenum and then goes into the intestines. And that's where that pancreas duct connects to help with the digestion. They are also they have ducts that come from the liver and the gallbladder. So they all play a part in getting the body ready to digest, to absorb. So the stomach is that first stage. We masticate our food, it goes down the esophagus, it gets into the stomach, and then once it's in the stomach, it starts being broke down with the stomach acid. And then the gastric juices are aided by through the ducts of the pancreas, the liver, and the gallbladder to break it down even more as it gets ready to be dumped into the small intestines. So the liver, just like the pancreas, secretes the bile to aid in digestion. It also removes poisons from the blood. It is a filter for us. It protects the immune system because it carries immune agents that help with infection. It removes germs and bacteria. And so it, again, is like a giant filter for your body. You can have conditions that you're probably familiar with, like jaundice. When a person is having problems with their liver, they turn very yellow. And I'm trying to look at my desk to see if I have anything that ends up being that color of yellow. And I can find an old lottery ticket here or something, but you see that yellow there with the little Texas hat? That's kind of what it looks like. And it can get really, really dark. And you know, when you see a person that has that color of jaundice, that they are having problems with their liver. All right, then we have the gallbladder. The gallbladder stores bile, but it releases it as we need it. And it is attached to the liver by the cystic duct. And that's why when a person has a problem with their gallbladder, they call it cholecystitis because of that duct. They're talking about the cystic duct that connects the gallbladder to the liver. Once we get past the stomach and that pyloric sphincter dumps into the duodenum, and some people call it duodenum, I call it duodenum. After that, it goes into the jejunum and the ileum. Now, those are the three parts of the small intestine that it's a good idea that you memorize. What you can do is, most of the ICD manuals, not all of them, will have a drawing of, and maybe even a color image of, the abdominal cavity in the front of your manual somewhere, and it'll show the small intestine. Well, go in and draw arrows. So the duodenum is right at the top as soon as it dumps out of the stomach. And then the next area is the jejunum, and the next area is the ileum. Why would it be a good idea for you to memorize this? Because if you're going to scope somebody, they end up going at certain points of the small intestine, and that changes the code, right? So whether you're doing a PCS code, a CPT code or not, the level of depth, or how far you go into the intestines from the point that you start, whether you are going an upper scope or a lower scope, it's based on how far you get. That actually completes digestion. Okay, so the digestive process happens in the duodenum, the jejunum, and the ileum. That's where the body absorbs the nutrients, any nutrition from whatever you're eating or drinking. The transport, the residue that's left over after all of the good content has been sucked out of what you've eaten, goes into the large intestine. Now, the large intestine is the beginning of the waste process. This is everything else that's left. The intestines themselves, the small intestines, are very long. And you can, I don't know how long they are, but it's significant. If you want to go take some time and you can look that up pretty easily, how long the intestines are. If you've ever watched a horror movie and they cut somebody open and those intestines all fall out, that's exactly what happens. But you know, there is lots of intestines because it takes a long time to absorb the nutrition. Okay, it's actually suspended in the abdominal cavity, there is a mesentery that holds everything into place. It's not really like I wouldn't think of it as a sac per se, but it is a covering that keeps all of those intestines in place. And it's not pressurized, but there is this like hemostasis that goes, around there. If you have an obese abdomen, then you have additional fat that pushes on that mesentery area. The large intestines is connected to the small intestine at the ileocecal valve, right? So that is a valve, unlike a sphincter, the pyloric sphincter at the top. So the large intestine, do the same thing with the large intestines. If you have that graphic of the abdomen, you can just draw little lines and divide it up. You have the cecum, the colon, the rectum, and the anal canal. What's a little bit different here is that we are still, it has the ability to absorb, but it's not the nutrients that we're getting off of the food. It does absorb electrolytes. Okay. And we all know what happens when we get low on electrolytes. That's how they came up with Gatorade, right? The football players, if you ever read that story about how Gatorade was invented, they had to figure out a way to get the electrolytes back into the system of these athletes that were out in the sun. You spill those electrolytes when you sweat and do heavy activities. So that is absorbed in the large intestines. It also stores waste, feces, until it's eliminated through the body. The appendix is actually part of the cecum, and it's this little finger that just kind of hangs off of the cecum. So if you don't know where the cecum is on the digestive tract, just look there at the end and you'll see that little finger, and that's the appendix. So now we're going to talk about diseases of the digestive system. So if we go back to the oral cavity, let's talk about things that happen to the salivary glands and the jaw itself, because that's how we masticate, is with our teeth in the jaw. If the bones of the jaw, you have the mastoid bones and you have the mandible, which is and then you have a TS joint right here. So if a person loses all of their teeth, that is called endotulicism. If you have a stone in the salivary gland, it's sialiothesis, and you're probably not going to see that written out. They'll just say it's a stone. It's they'll even say it's an SG stone sometimes, and it can be very small to where you can't even hardly see it. My youngest, number 6, when he was really, really little, he got one, and we thought, oh my word, a whole side of his face swole up and just seemed to be getting worse throughout the day, but he wasn't sick. He didn't have an earache, never had, at that time I was like, I don't know what's going on. Is it something really bad? Took him into the doctor, and the doctor said, oh no, he has a salivary stone. And he said what he needs to do is just get him a bag of lemon drops, and just every hour, as many as you can get down him, just make him suck on those lemon drops, and it'll finally come through the gland, and then that swelling will go down right after that. And it did. And for the most part, that's what happens when that duct gets clogged with a stone. But there are times when the stone is so big that you have to do a procedure where you just open it up and pop it out. I've seen some that are size of marbles. They're not perfectly round like that, but they can get really, really big. Then mucositis is an inflammation, or you can have an ulceration of the oral cavity. If you've ever had braces, you probably had that happen inside your mouth. If you ever get any trauma to the inside of your mouth, it'll get inflamed, and sometimes it'll go ahead and ulcerate. What happens when you have a patient that is admitted for chemo for pancreatic cancer, and then they develop oral mucositis due to the chemo, which was administered via a central vein? Hmm. That would be, what are we going to code for? So the mucositis is a complication, a direct result of the chemo, right? So it's a complication of the chemo. And then we have to code that the patient has pancreatic cancer. Esophageal conditions, we can have esophageal varices. Now, if you're looking at these recordings in sequence, you may have heard us talk about esophageal varices in the cardiovascular because varices is a vein. It's like having varicose veins in the esophagus. uh, this can be complicated if they rupture and you have bleeding or hemorrhage involved there. What we would do with that is they can go in and they can do repairs, but sometimes it causes pain as well, and difficulty and obstruction in being able to swallow. Uh, they are so they're excluded from the code for gastrointestinal hemorrhage. It's not the same. Okay, so esophageal varices that bleed is not considered gastrointestinal hemorrhage because gastrointestinal hemorrhage starts from the stomach, which is gastro down. Right. So don't get confused if you have a esophageal hemorrhage and it's, due to an esophageal varices. That is not gastrointestinal. The uh, code will be in a different area. Okay. So that would be in the circulatory system because the varices is part of the vascular system. If you've never heard of Mallory-Weiss syndrome, what is that's happens when you get a laceration in the esophagastric junction. That's down low at the bottom of the esophagus where it connects to the stomach. This is something that happens if that's a compromised area. What usually happens when as a result of this is that the person will start throwing up for a couple reasons. One is that that's the response, right? Because you have a hemorrhage, but also blood in the stomach makes you nauseous and it comes back up. Esophageal reflux is really common. It's also called GERD, and that's it's gastroesophageal reflux disease, GERD. So when you look at the code for esophageal reflux, it will say GERD. And when you look up GERD, it'll say esophageal reflux. Now, that is different than other types of it's not gastric reflux, it's esophageal uh, it's gastroesophageal reflux. Okay, there's more than one type, and pay attention to your excludes notes to make sure you are that it's actually GERD that the patient has. The treatment for that would be proton pump inhibitors, and it just kind of suppresses the production of the gastric juices in the stomach. Prilosec is, now it's over the counter. Prevacid is also used for that. I had this for a while and it wasn't over the counter. I tried Prilosec, it didn't work as Prevacid, so I took Prevacid for a long time and it healed up the area that was damaged in my esophagus, lower esophagus. If it gets too bad, they can go in and do surgery. If it's not treated and it goes on for a long time, it can turn into Barrett's esophagus. Now, Barrett's esophagus is different. That is a precancerous condition. And the reason that it's precancerous is that, remember I told you that the inside lining of the esophagus is very specific, and that's a certain type of tissue there. Those cells are very specific. They're esophageal cells. The stomach has a different type of cell. Okay, they're gastric cells. When you have reflux going up into the esophagus again and again and again, and that irritation develops, when you have a constant irritation, and I use that example, rubbing like this constantly, eventually that's going to heat up and may even, create a scab or something. That can happen from acid being pushed up into the esophagus over a long period of time. Well, the esophagus will, I like to think of it, just gets finally tired of it. And the stomach cells, the gastric cells, will start growing up into the esophagus, the lower part of the esophagus, to protect itself, right? So then you have gastric cells in the esophagus. What happens when you have cells that go or do what they're not supposed to do, right? That's precancer. And so Barrett's esophagus is a serious condition. If a person has chronic GERD, then that's something that they always check you for. The symptoms are going to be like GERD. You're going to have the heartburn, ingestion, difficulty swallowing solid foods, and nocturnal regurgitation. And what that means is you lay flat and you get reflux coming up. Anything that you eat will come back up into the esophagus. And Barrett's esophagus has its own code. It's very specific. GERD and Barrett's esophagus. Now, talking about ulcers of the stomach and the small intestines. If we have a gastrointestinal ulcer, so if it's gastro means stomach and intestinal, that means that it can be, both. It's an open sore in the lining of the stomach or the intestine. So think of the inside of your mouth when we talk about getting a cold sore or a little ulcer inside your mouth, how uncomfortable that is. I remember one time when I had braces as a kid and I got hit in the mouth with a ball. We were playing probably dodgeball or something, but it was at school. And I got hit in the mouth and it hit those braces all along one side of my face and just chewed up, just really those metal braces chewed up the inside, top and bottom. Well, within 24 hours, I had a mouthful of ulcers and it got so bad where I couldn't eat. It hurt, it was uncomfortable, even swole a little bit. The outside of my face didn't take any trauma, but the inside of my mouth just was horrible. I ended up going to the doctor because I couldn't take it anymore. And they ended up giving me a mouth swish that was Benadryl and Maalox was mixed 50-50. You shook it up, you put it in your mouth, and you just let that sit in there, for a minute or two, and then you spit it out. Well, what it did was the Benadryl was an anti-inflammatory, and the Maalox was too. It soothed an ulcer, so it was pretty cool. I thought that was a neat thing to get. It worked great, kind of numbed the area. So imagine that if you've ever had a cold sore in your stomach or in your intestine, it would hurt anytime anything rubbed across it. Causes usually is too much stomach acid being produced, and you can get a bacterium known as H. pylori, and it's actually the Helicobacter pylori bacteria, but they say H. pylori, and they'll check you for that because if you have that in your stomach, then it'll produce these ulcers. Drug-induced usually is what happens. Symptoms: pain when eating, vomiting, and tarry bowel movements. And tarry is tarry, not Terry. I said it wrong. Tarry. So if you've ever seen that, it's black and sludgy, and that means there's blood. So when it comes up from the stomach, if blood comes up from the stomach and it's not bright red, but it's been in the stomach for a while, it'll come up like coffee grounds. If it goes out the other way, it'll come up like black tarry stools. Diagnosis: well, you can do an upper GI X-ray. You can do a blood test for H. pylori, stool samples, of course, and we can do an endoscopy. And I know I've been scoped a few times because I had I had burnt a little hole in my esophagus from eating too much ibuprofen, and it was like eating it. Come to find out I was having kidney pain, but I thought I had low back pain, so I was just popping ibuprofens like crazy and ultimately burnt a little hole. And that's why I took the Prevacid for so long. So I'd been scoped several times, had heartburn and things. Uh, but you'll always notice when they check you, they'll check for H. pylori and they'll check for Barrett's esophagus. Those are things that they'll always rule out when they go in and scope you. Treatments and acids. Proton pump inhibitors, meaning they're going to reduce the production of stomach acid, and there's histamine receptor blockers as well that are helpful, which ends up being like Benadryl, right? If a person is diagnosed with H. pylori, they give them the antibiotics will take care of it. It's a bacteria. But there are sometimes if it gets so bad, they can go in and do a gastrectomy. And again, you can go without your stomach if you have to. Other things that could happen is blood loss anemia. So pay attention to that. If a person is having a bleeding ulcer, a bleeding gastric ulcer, they are probably going to be anemic. Also, they can get gastric outlet syndrome. So I'll let you go look that up as a little additional homework and understand what gastric outlet syndrome is. If you have a gastric ulcer, it's actually in the stomach. If you have a peptic ulcer, that's in the esophagus. It can be in the stomach, duodenum, jejunum, or the ileum. Okay, so a gastric ulcer is always in the stomach. Gastric means stomach, but a peptic ulcer can be anywhere in the digestive system. If you have hematuria, that is bright red blood in your stools. Now, whenever you have anything that deals with bleeding in the gastric or intestinal system, it usually comes out as that black tarry stool. But if it's in the lower GI, then it could be bright red stools. Don't confuse this with having hemorrhoids. If a person has hemorrhoids, they could have bleeding with bowel movements, and that'll be bright red as well, which is technically the same thing, okay? But if it's really excessive, that may be up, it's somewhere in that lower GI area. Hematemesis is throwing up blood. It'll always be in the upper GI, and it can be bright red if it's like varices again, but if it's coming from the stomach, it's going to look like coffee grounds. Whenever there's any type of a GI bleed, then it needs to be seen. It could end up being an emergency, whether it be coffee grounds or tarry stools. That means something's been going on for a while, right? Bright red blood, if it's just a little bit, again, it could be like a hemorrhoid or something. But if you're throwing up blood that's bright red, yeah, that's really a bad thing. You need to go get that checked out right away. Melena is dark stool, and again, it's tarry. Occult is a blood in the stool, but they see it via laboratory test. They'll do an occult test, and what they'll do is they'll take a little bit of stool and they'll put it on that little card and go in and check it. And this will let them know, hey, is this an upper or lower GI bleed? Anemia can be present, and if a person is suffering from anemia, then and they can't figure out why, then it could be a GI bleed, because we're not going, maybe we're not throwing anything up, but if it's a lower, and and then they'll start asking questions about what the stool looks like. And it may be such a slow bleed that, we're not getting that black tarry stool. Other common causes, you can have gastric or intestinal ulcers, of course, hemorrhoids, which is just enlarged veins, and then diverticulitis. Now, diverticulitis is a little bit different because that's in the large intestine, and there are little pockets that develop, and those little pockets or balloons that develop can become infected, and they are very, very painful. So if a person has diverticulitis or diverticulosis, they will have to change their diet. They won't eat things that have seeds like strawberries, because those little seeds will get caught in the little pockets and then cause irritation and infection. If you have angiodysplasia of the intestines as well, can be a cause of gastrointestinal hemorrhage. Be careful, because there's causal relationships whenever you have bleeding at a specific site. And it's a good point. Do not assume testing equals findings unless it's documented, because we don't read the lab tests, right? In fact, we don't even care what the results of the lab test were. We look at, oh, there was a lab test done that confirms that they're looking at X, Y, and Z, especially if you're doing risk adjustment. But it also shows us medical decision making, things like that, right? And helps us think, hey, what's going on in the disease process? But it's not our job to read the results. But when we see that lab tests or things like that are done, then we know we're going to be getting findings and a diagnosis to a higher specificity, most likely. Appendix. Well, of course, the most common thing that we think of is appendicitis, and that's an inflammation of the appendix, and it's that little finger. It's not that big, too. It can have an obstruction, and then it becomes infected. So our signs and symptoms is, of course, abdominal pain. Your appendix are actually located in the right lower quadrant of your abdomen, but you can have pain in other areas of the abdominal cavity, and then right before it gets really bad, it usually ends up moving to the right lower quadrant. And this is called McBurney's point, and you'll see that mentioned in documentation. Absolutely, nausea and vomiting happens with appendicitis. Won't want to eat anything, anorexia, fever because it's an infection, it's gotten infected, constipation, can't go to the bathroom, and we'll have an elevated white blood count because we have appendicitis, right? An infection. Even there are some studies where people have come in with some of the signs and symptoms. They thought it was something else. They go home, they get real bad real fast, come back, and then they have a over-the-wall elevated white blood count. Some other little tips just from working in the ER for so long on appendicitis. These are people that can't sit still. They're in a lot of pain. One of the things you can't do if you have appendicitis is jump. So put your feet together and jump. And if that brings a person to their knees, that's probably appendicitis. Another thing that they can do is on the right leg, have them lay flat, slap the bottom of their foot, and they're like, ugh, for some reason that is an indication. But, we thought my son had appendicitis. He had all of these signs and symptoms, except he didn't have an elevated white blood count, which can always come later. His ended up being, after they did the CT scan, a kidney stone, which is terrible to have when you're 13. And I felt really, really bad because that's young to have a kidney stone. So, but ultimately I was pleased because appendicitis results in surgery. There's no other choice. And I really didn't want him to have surgery. So he was able to pass his stone. Treatments is antibiotics and surgery. Again, no other choice. You got to have surgery. they will do a pathology report on the appendix itself when they remove it and send it off. And the appendix can rupture. So if it ruptures, then it can become life-threatening because you can bleed out. Not only is there blood now in the abdomen, but there's infection in the abdominal cavity. And that has to be irrigated and cleaned up really well, or it can cause other types of problems because we just don't want infection floating around in the abdominal cavity. Signs and symptoms end up, if they lead to an appendectomy and the pathology report indicates it's a normal appendix, then you code the signs and symptoms, not appendicitis, okay? Hernia. Ultimately, what a hernia is, the muscles of the abdomen are like this. Okay, so you've got the muscles in there like that. When the muscles separate like this, let me do something on something dark. They open up and they separate. The intestines can poke through. Okay, now if the intestines poke through and then you can push them and they poke back, that's okay. You can have that hole there. Okay, so it pokes through. But what happens is that intestines pokes through like this, okay, and then twist, and there's a torsion. Okay, now if that happens, what happens if you take a tube that you're running some liquid through or something through and then you twist it? What happens when you make a balloon animal, right? You don't want that happening to your intestines. It will cause severe pain, it will cause obstruction, and it can get so bad as it turns into gangrene. And that's just like having your appendix burst. It can also burst. So hernias is a protrusion of an organ or tissue through an abdominal opening. Often the organ ends up being the small intestines, but it doesn't have to be. Hernia is the intestine is the most common one, but there can be herniations in other parts of the body. You want to know, is it congenital or acquired? Right? That is something that you're going to see in the documentation, as well as you're going to see in your coding to get to the highest specificity. They're going to know they want to know what type it is, and they want to know the site, the location of the herniation. They also will ask in the coding, and it'll be documented, is it obstructed or is it have gangrene or gangrenous is what it will be documented. So again, if you have, and it'll be unilateral or bilateral because you can have more than one, okay? Whenever you see this documentation, you'll also see they'll state whether it's reducible or not. And what that means is if you have intestine coming through, can they push it back in or not? And if they can't, that's not a good sign. Well, it's not a good sign ever to have it, because if it can move in and out and it that gives it more likely the ability to twist. But if it gets out and it stays there, then it can get strangulated, right? So coding a hernia, there's a whole lot of steps that you got to abstract from the documentation. First thing you ask, is it congenital or acquired, right? Is it, let you know the type and what site, where is it located at? Is it obstructed or is it gangrenous? And then unilateral or bilateral, and then also reducible. You'll see that in there. So where can you have, or what types of hernias can you have? Well, inguinal will be intestines down by the inguinal canal. Femoral is going to be intestines that are down by the femoral canal, which ends up being at the top of the thigh, right? The femoral area. Why do we need to know the terms for the bones and things? Because they're locational, right? Umbilical will be right there by the umbilicus, the belly button, and the incisional happens because they've had a scar, they've had a procedure done, and they've got a scar, and it has weakened that area, and then it's poked through. Ventral, that is going through the abdominal wall, usually midline is what they'll see. And diaphragmatic, right by the diaphragm. So the diaphragm allows part of the organ to slip up into the chest cavity. So remember when we've talked about the diaphragm, and it's a muscle that the lungs are here, and then right underneath here is your liver, and your stomach is right there. But through the diaphragm is your the esophagus. The stomach is underneath, and the esophagus is here. And what happens is the stomach. So say your fist is your stomach. This is your esophagus, right? And so it sits right there on that, and so it moves up and down because you're breathing. Well, what happens is this weakens, and the stomach starts to pop through. Okay. And that's diaphragmatic. And it causes heartburn. And if you think about it, your heart's up there. So it starts pushing on your heart. We can have non-infectious enteritis and colitis. That would be Crohn's disease. Very difficult disease to live with. The GI tract is, especially the small and large intestines, are inflamed, and it kind of runs like a constant inflammation. Abdominal pain and diarrhea, you just live with it. It's a constant in your life. What do? Well, they can give you medication to help it and treat the signs and symptoms. Steroids help. Immunosuppressive agents have been known to help. Biologic response modifiers can assist with it. Ultimately, you go through bouts of antibiotics, and you often also will get dehydrated because you get diarrhea so bad. Sometimes they'll do surgery, and they'll just take out the part of the intestine that is diseased or has that chronic inflammation, and then that'll give people relief. If you have ulcerative colitis, that is an inflammatory bowel disease. Ultimately, what happens is that lining of the rectum and the colon produces ulcers. Okay, so think of that lining being like the inside of your mouth too, at that mucosous membranes, and then having mouth ulcers in your rectum and colon. Not fun. Gastroenteritis is going to be the stomach and the intestines that get inflamed. It will be the cause of like a virus, and it'll last a day or two, where they have diarrhea and stomach cramping and everything. If it's bacteria, though, it can last for over a week. What they'll do is they can go in and test the stools. Often what happens, it's a chemical toxin of some type has gone in and irritated. If it's non-infectious. Gastroenteritis is usually due to viruses and bacteria, and it can be there'll be other codes to identify what the bacteria or virus is. So you can end up with more than one code. If you don't know what it is, then you can always go to enteritis. And that's how you're going to find the code. So you're not going to find gastroenteritis in the index. You're going to go to enteritis, and then it's going to say gastroenteritis. Make yourself a note of that, or you're not going to be able to find it. Gastroenteritis is enteritis in the index. What happens if we have an intestinal obstruction? Well, when you have an obstruction, that means a blockage. And what is happening with our intestines? The whole digestive tract is tubular, right? And so it's flowing, and it's flowing in one direction. If you have an obstruction, there's going to be a backup. So if you have an obstruction in a creek and a tree falls over, what happens? It overflows its banks. And if that happens in your body, it is going to cause pain, and can even cause infection. So ultimately, you can have more than one type of blockage: partial, complete, mechanical, or functional. So they want they'll see that in the documentation. They'll let you know. And so you're going to ask yourself, is it partial or complete? If you have complete obstruction, nothing's getting through. If you have partial obstruction, then it's getting through, but it's usually very, very slow. And is it mechanical or functional? Diverticulitis and diverticulosis. Diverticuli is those little small pockets that I told you about. They happen in the mucosous membranes of the intestine. Diverticulitis is the inflammation, but diverticulosis is diverticuli. Diverticuli, it's plural. It's like plural. If you have diverticuli, that means that those intestines have pockets already there. All right. If you go in and you get a lower GI, they're going to be able to see that. They can get inflamed. They can get infected. And then it becomes diverticulitis. It's a very painful condition, makes you very, very sick. When you have documentation, what are you going to look for? You're going to want to see that the patient has diverticulosis with diverticulitis. All right. So if a person has diverticulosis, that means that they have those pockets. If they have diverticulitis, the pockets are now irritated and inflamed. Okay. Other things can be going on to get diverticulitis, like peritonitis. You can have a perforation, maybe a fistula. If a bowel obstruction occurs, then you can get diverticulitis, or a person can have an abscess in the intestines. Moving on to the peritoneum and retroperitoneum, you can get peritonitis, and that is a infection of the peritoneum. Usually this is a bacteria, but it could also come from a fungus that develops. Fever is what you're going to see, definitely abdominal pain, and sometimes there's distension in the abdominal cavity. Nausea and vomiting will result. What happens? Well, sometimes people have peritoneal dialysis, where instead of having dialysis where you have the fistula in the arm and they plug you in and dialyze the blood, it actually goes into the abdominal cavity. A shunt is created and then the body absorbs that. Cirrhosis of the liver can cause this, because what is our liver? It's that filter for us. And if cirrhosis of the liver is almost like a hardening and disease of the liver, ascites is just fluid buildup. Ruptured appendix, right? Because if your appendix rupture, you have inflamed and infected tissue as well as infection that fills up in the abdominal cavity. Stomach ulcers, perforated colon, which would be just as bad as having your appendix blow up on you, because right, your stool is going to leach up into the abdominal cavity. Pancreatitis and diverticulitis all can cause peritonitis. So the whole abdominal area gets irritated. Treatment, IV antibiotics. Absolutely, you'll be on IV antibiotics, but you might even have to have surgery. Expecting so, because if you have a perforated colon, right, they're going to have to go in and do repair, and they're going to have to clean that up. So anytime the abdominal cavity itself has anything that's not supposed to be in there, then you got to go clean that up. If the organism is identified that's causing the infection, then of course you're going to code that as well. Cirrhosis of the liver. Well, this is degenerative, and it causes blockage of blood moving through the liver. Now, how does the liver work? It's a filter. So even though it's not shaped, flat, and everything, but think of it as your coffee filter. Okay. If your coffee filter that you use is clogged, right, hardens up, and then the coffee grounds sit there, and then it can't leak through the rest of it, then you got a problem. What are the most common things that happen that cause cirrhosis of the liver? Well, alcoholism. The body just can't, chronic drinking of alcohol is the body can't filter that out through the liver. And hepatitis, which is an inflammation of the liver itself. Hepatitis can cause that. So what is Hepatitis, it's an inflammation of the liver. It can be chronic, or it could be short-term. You could have a short inflammation, or it could be the rest of your life that you have it. Hepatitis is caused by a virus, so it's not like we can give you antibiotics to cure hepatitis. It's a digestive disease, and it can be divided up either in drug-induced or alcoholic hepatitis. Okay. Toxic hepatitis, that means that the body's been exposed to some chemicals or drug that's actually damaged the liver and then resulted in the liver being inflamed. Once that drug is taken away, then the hepatitis goes away. But sometimes it leaves permanent liver damage. Have you ever seen a beef liver? It's very, very soft. The tissue is dark, bright, burgundy colored, but it's so soft that it's so very easily damaged. Over-the-counter drugs can be toxic. Advil, Motrin, Tylenol, all those NSAIDs, Tylenol's not an NSAID, but Advil and Motrin, they can be hard on the liver. So an overdose of ibuprofen is really, really harmful to the liver. Prescription drugs, all your statins are going to be involved there, but ionized and methotrexate. Let's now look at the gallbladder, biliary tract, and pancreas, cholelithiasis and cholecystitis, abnormal conditions of stone in the gallbladder. So gallstones, very, very painful. It's usually asymptomatic until a blockage occurs. So you don't even know you got stones in your gallbladder until a blockage, and then that little old gallbladder gets inflamed and irritated. If you have an acute condition resulting from that blockage, it'll be cholecystitis. Okay, and then the result of that is a cholecystectomy. They'll go in and they'll take out your gallbladder. Look for documentation of stones, gallstones. They can be acute or chronic. They can be obstructing or not obstructing. Okay, so they're going to want to know that in the documentation to be able to get to the highest specificity for your codes. I actually had my gallbladder taken out. It's very common for women, and they call it the 4 Fs that classify that it's probably your gallbladder when you come in with the signs and symptoms. You're fat, female, 40, and fertile. And when I had mine out, the surgeon was telling me that mine was an acute thing. It happened within 24 hours. I was in the ER twice. And mine had no stones. It just got infected and rotted all of a sudden. So he told me, he said, well, you've got the 4 Fs. And I said, no, I don't. I'm only 38. So anyway, it's common for women. More things in this area is be aware of an ERCP. This is an endoscopic retrograde, let's see, cholelangiopancreatography. What it does is it looks to see if you have gallstones. An ERCP. Now you know why they write ERCP, because nobody wants to say that. And they're just scanning for gallstones. If you have let's see, it's cholelithiasis, that's a stone that gets stuck in the bile duct. Very painful. Pancreatitis, inflammation of the pancreas caused by gallstones, or it could be chronic alcohol use. Pancreatitis could also be caused by problems with the production of insulin in the body. Diabetics have problems with pancreatitis or cancer, pancreatic cancer. It can be either acute or chronic. The pancreas is up in the upper abdominal area, and it'll end up shooting back through the back. It's extremely severe pain, they say. Never had it, but I've known a couple people that had pancreatitis, and it was they said the worst pain they'd ever felt. Blood work ends up telling us that they have elevated levels of lipase, or let's see, that's pronounced amylase. Yeah, amylase. So what do? Well, you go in-house. It's very dangerous, actually. You go on IV fluids, they give you pain meds, and you don't get to eat anything. Then they also do the ERCP. Is there a stone causing this? The procedures that they can do a sphincterectomy. They can do a sphincterectomy, gallstone removal. So they just go in and take out the gallstones. They can put a stent in, so it allows, if stones are produced, they can move back and forth. And they can also do a balloon dilation to open up that duct. If you have chronic pancreatitis, then you can end up damaging the pancreas. When a person has alcohol, if they're alcoholic, then that can cause pancreatitis. Ultimately, the complications is you get malabsorption of food because the ducts are being clogged that allow the body to release enzymes to break down the food so that we can absorb it in the intestinal tract. So malabsorption of food and diabetes. Now we're going to look at the Z codes. Again, personal history of, family history of, status post-pancreectomy, right? Acquired absence of gallbladder. They don't really pull that on there, but acquired absence of a particular organ, meaning they've had it removed via surgery. Fitting and adjustment of a coleostomy. Attention to fitting, attention to coleostomy. Special screenings for malignant neoplasms as well will all be Z codes. Now let's talk about some of the medications that are used with these diseases we talked about. With GERD, we already talked about Prilosec, Prevacid. Zantac and Tagamet went over the counter before Prilosec and Prevacid. Reglan is a medication that doesn't reduce acid, but it slows down the peristalsis waves. And Propulsid, I'm not as familiar with that one. Crohn's disease has corticosteroids are often used because it's an inflammation, and gastric ulcers, Pepcid, Axid, Prilosec, and Nexium. Gastroenteritis, definitely going to be on IV fluids. With gastroenteritis, you're going to throw up and you're going to have diarrhea, so you're going to have medicines to treat that. Pancreatitis, you don't get to eat, and they pump you full of antibiotics via IV. So the procedures that we're dealing with. Now we're going to move to the PCS codes. If we do any procedures on the throat, med-surg, O, then we're going to be doing C, which is body system, and it's going to be O through X as our root operation procedures for the mouth and throat. For gastrointestinal, we'll do med-surg, which is O. D is the gastrointestinal system, and then you have the options of root operations I through Y. The root operations, that third character is what's the outcome of what you're going to do. If you're going to remove something, if you're going to do a cholecystectomy, then that's going to be the third character that's telling you that. Hepatobiliary system and pancreas will be O for med-surg. F, because that's hepatobiliary and pancreas body systems. And then your third root operation will be 1 through Y. Again, what are we going to actually do? We're going to place a stent in the hepatobiliary tract. If we do a Nissan application, that is to treat GERD. So the upper portion of the stomach, which is the fundus, remember I told you that you had your esophagus, and then the stomach is like this. It arches, and then it comes down and curves up, and then here's the pyloric sphincter. This is the fundus. It's the upper portion of the stomach. It wraps around the lower portion of the esophagus, and it prevents reflux into the esophagus. If we do a PEG, we're doing a percutaneous endoscopic gastrotomy, and they put a tube into the abdominal wall, and then they feed you through that tube into the stomach. Endoscope only used to insert the PEG tube, so it will be, the tube is put in percutaneously, and then they may use endoscopic guidance, and that's included. If we do an EGD, that's an esophageal duodenoscopy, and mainly they're going in and looking through the esophagus, into the stomach, and through the duodenum. They want to go look at all those body parts, the esophagus, stomach, and duodenum. And why would they do that? Well, they're going to look for Barrett's esophagus, blah, 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 right? But they'll probably do, the procedures are, they're going to do a biopsy. They need to take some of the tissue to see if you have Barrett's esophagus. Maybe there's a lesion or a polyp that they need to remove. Maybe there's an ablation. You've got Barrett's esophagus, so they need to kill those cells, those gastric cells that have gone up into the esophagus. Hemorrhage control. Maybe you have the esophageal varices, or dilation. You have a stricture of the esophagus, so they're going to dilate the esophagus itself. If we get a colostomy, they put an incision into the colon, and they make a stoma, and then it bypasses exiting the body through the regular route through the colon and rectum, and waste is released out of the stoma. It's a substitute for the anus, ultimately, is what it is. And it really depends where the diseased part of the colon is as far as the placement. Most of the time, colonoscopies are temporary. So they're letting something heal, and then they'll reverse it, is what they do. You could have a sigmoid colostomy. That is actually the most common type. If you don't know what that looks like or how they do that, you can go all over YouTube and see that. Go Google image a sigmoid colostomy. If you have a patient that is admitted to close or reverse, and they use the term also take down the colostomy. So the colostomy's done, it served its purpose. Now we're going to put everything back together. Then you're going to use Z43.3 because it's encounter for attention of colostomy, and we're going to reverse it. We're going to take down. Often, if you're closing a colostomy, they might do some trimming of the colon, and so that they can complete the anastomosis. And that anastomosis just means they're bringing the two tubes back together. Ileostomy, same thing as a colostomy, except for we're in the ileum instead. That's why you need to know what's the difference in the different areas of the intestines. And so again, it's a small intestine, and it's at the ileum. Other ostomies that happen in the digestive system are listed by location. The first thing they're going to want to know is there any complication of the ostomy? If there is, then it's a complication code. Okay. If you don't have any complications, but they need to do something to it, like the takedown, change a catheter, anything like that, then it's attention to is where you're going to be coding. If there's no complication, there's no attention, then you're going to just use Z93 codes. So go look in your tabular to Z93 and familiarize yourself with any guidelines, excludes, or additional information that you need for Z93 codes. Because you don't know they exist, then you won't code them to the highest specificity. What happens if we do a bowel resection? Well, often this is because a person has a neoplasm, right? Maybe they have cancer. Sometimes diverticulitis is so bad that they go ahead and they're just going to cut out that portion of the bowel. Sometimes there's perforation. Perforation often happens because of severe diverticulitis. Or you could have a bowel obstruction, and then they need to just go and cut that out. If that does happen, again, they'll do an anastomosis, and that's where you're putting the tubes back together. Okay, because the whole digestive system is tubular. If we do an appendectomy, we're taking out the appendix. They can do an incisional or they can do laparoscopic, and that's what you're going to want to know. Is it open or closed? Right. Be very careful, because sometimes when you're doing an abdominal procedure, it's an incidental appendectomy could be performed, and that also can be done open or laparoscopically. So an incidental appendectomy means more or less we went in, we were going to do something else, or we were doing something else, and they went ahead and took your appendix at the same time. A cholecystectomy is going to remove the gallbladder, and again, it can be doing open and closed, incisional or laparoscopically. Mine was laparoscopic, and that's for the most part how they do it now, but sometimes there's reasons why they have to go ahead and do it incisionally. I remember my surgeon said on the 5th attempt, he said, if I can't get it this time, I was going to open you up, but I got it because mine was all slippery and slimy, he said, and he said he kept dropping it. Common bile duct stones, they can remove them via incision, they can do it endoscopically, and they can also do it percutaneously. If you have a cholecystectomy, then you might have removal of the common duct stones as well, but if you do, then you're going to code for both, the removal of the stones as well as the cholecystectomy. Extracorporeal shock is lithotripsy, and it's ESWL. They break the stones up with shock waves. Now, the stone itself, also they do this with kidney stones, but the stones usually have to be a certain size, and then they'll just zap them with those shock waves, they explode, and then they can go ahead and pass. Now, with an ERCP, there's other things that can be done. They may be doing a stent insertion to keep that duct open. Maybe they're doing a sphincterectomy where they take out the sphincter area, or they're just removing the stones. All of those are procedures that could be done. If they do a lysis of adhesions, then they're destroying the adhesions, and adhesions happen throughout the whole abdominal cavity. Our intestines are all stuck in there and pushed in there, but there's little adhesions, little pieces of fibrous tissue that hold things in place. And when you go and look at an abdominal procedure, whether it be laparoscopic, because you can see it on a camera, or open, you'll see them in there like cutting away those adhesions to free up the organ or the tissue. Now, sometimes, we have adhesions all over inside our body, and they around our muscles and stuff like that. For the most part, they don't bother us at all. But every once in a while, if they're doing a procedure and they need to get in there and they need to separate them, or it could be causing problems and constrictures. Adhesions are also used synonymously with scar tissue. So if you have had several abdominal procedures and it builds up scar tissue, that's considered an adhesion. They can cause abdominal pain and need to be taken care of. A herniorrhaphy is repair of a hernia. That's RAFI. Again, just to reiterate, where's the hernia located at? Is there laterality involved? Did they do it direct or indirect? And if they repaired it, did they put in a prosthetic or a graft? Now, when they do a prosthetic, they've got a mesh that they place in there and sew in. It's almost, it makes you think of a little, wanted to think of it, a little mesh. Think of chicken wire really tiny. They push it in there and then nothing can get in, right? Or they may take graft tissue to help protect that wall. If we do a TIPS procedure, it's a transjugular intraheptic protosyntemic shunt. And they'll do this, the interventional radiologist will do this, and usually this happens when people have liver disease. They can go in and they tunnel in percutaneously. They go through the liver with a needle, and they get the portal vein and they connect it to one of the hepatic veins. Sometimes they'll put in a stent, but that allows that to flow, free flow, keep that tract open, and procedure does not improve the functioning of the liver, but it helps treat the complications that are involved. And that is wrapping it up. We did good, and I've really enjoyed getting these little words of wisdoms or quotes, and this one I picked out specifically for us today. If more of us valued food and cheer and song above hoarded gold, it would be a merrier world. Right? Does that make you think of your digestive tract? All right. Don't forget, if you have any questions, go to the club, ask your questions there, and they'll be answered right away. Share anything. Share and let us know if you had your gallbladder taken out before, or your appendix, and what your experience was like. If you're watching us on Facebook or YouTube by any chance, don't forget to like and subscribe, and go check out the club, because we love our people in the clubs. Thanks, guys. Have a great rest of your day, and happy studying.